Horner's syndrome or the ocula sympathetic palsy occurs when sympathetic innervation to the eye is interrupted. The dilator muscle of the iris is weakened, allowing the pupil to become smaller. A combination of ptosis, miosis and anhidrosis is called Horner's syndrome. The sympathetic supply of the eye involves 3 neurons. Horner's syndrome based on localization is diagnosed as first order or central, second order or preganglionic and third order, also known as postganglionic, based on the order of sympathetic neurons affected. Central or the first-order sympathetic neurons begin in the ipsilateral hypothalamus and extend to the ciliospinal center of Budge and Waller in the intermediolateral gray column of the spinal cord C8 to T1. The pathway seems to stay laterally in the brain stem and spinal cord, so Horner's syndrome caused by damage to central neurons is almost always unilateral. There is no pharmacological test to diagnose central Horner's syndrome, so associated clinical signs must be looked for. Hypothalamic lesions are usually associated with contralateral hemiplegia. Wallenberg's syndrome occurs due to lateral medullary damage. There is ipsilateral impairment of pain and temperature sensation over face, limb ataxia, dysarthria and dysphagia, and Horner's syndrome. Contralateral pain and temperature sensation are impaired over the trunk and limbs. Patients with cervical spondylosis may not have signs and symptoms of spinal cord disease but have neck pain and Horner's syndrome. Preganglionic or the second-order neurons exit from ciliospinal center of Budge and passes across the pulmonary apex, turn upward and pass through stellate ganglion, go up the cervical sheath to the superior cervical ganglion, near the bifurcation of common carotid artery. During its long course, it is closely related to the apical pleura, where it may be damaged by bronchogenic carcinoma like Pancoast tumor or during surgery on the neck. Ptosis and meiosis of preganglionic Horner's is nonspecific, but disturbance of anhidrosis is characteristic. The entire side of head, face and neck down the clavicle are usually involved. Postganglionic are the third-order neurons of the sympathetic pathway to iris. Dilator muscle extends from the superior cervical ganglion behind the angle of mandible and up along the internal carotid artery, where it is called as the carotid plexus, or carotid nerve. The external carotid artery carry the fibers for sweating of the face. This is the reason why postganglionic Horner's syndrome will not cause facial anhidrosis, because postganglionic fibers for facial sweating travel with external carotid artery. The sympathetic branches reach the ciliary body and the dilator pupillae muscle through the nasociliary nerve and the long ciliary nerves. Within the cavernous sinus, the sympathetic fibers from the internal carotid artery join briefly with abducens nerve and leave it to join the ophthalmic division of the trigeminal nerve, entering the orbit with its nasociliary branch. Sympathetic fibers in the nasociliary nerve divide into 2 long ciliary nerves that travel to reach the anterior segment of the eye and innervate the iris dilator muscle. Common causes of central, that is first-order neuron lesions are brainstem disease, syringomyelia, Wallenberg syndrome, cervical spinal cord lesion. Common causes of preganglionic, that is second-order neuron lesions, are Pancoast tumor, chest trauma, birth trauma, thyroid lesions. Postganglionic, that is third-order neuron lesion causes includes internal carotid artery dissection, cavernous sinus mass. Painful Horner syndrome, especially of acute onset, should raise the possibility of carotid dissection. It is the sympathetic action that causes dilatation of the eye, 1 to 2 mm of eyelid retraction, sweating of face and neck, iris color and ciliospinal reflex. So in Horner's syndrome there is miosis and anisocoria, which is more in dark, as in dark normal pupil will dilate whereas Horner pupil dilates slowly. Anisocoria more in dark is a key examination finding. That anisocoria is accentuated in dim light, since in contrast to a normal fellow pupil the Horner pupil will dilate only very slowly. The dark-induced anisocoria diminishes with time spent in the dark environment. Other clinical features include slight elevation of the inferior eyelid, that is inferior ptosis, as a result of weakness of the inferior tarsal. Small or sunken affected eye, apparent anophthalmos. Miosis is due to dilator muscle palsy, so the pupil will dilate widely after adrenergic stimulation due to denervation hypersensitivity, which is the basis of pharmacological tests. This weakness of dilator muscle is more apparent in dark because in light both pupils constrict due to normal sphincter pupillae. Mild ptosis, usually 1 to 2 mm, is a result of weakness of molar muscle and miosis due to the unopposed action of the sphincter pupillae with resultant anisocoria. Dilation lag can be detected when the lights are turned out. Horner's pupil dilates more slowly than normal pupil. Hypochromic heterochromia, that is the difference in iris color. The lighter iris as the Horner's pupil may be seen if congenital or long-standing cases. Depigmentation of ipsilateral iris is not usually seen in acquired Horner's but is a typical feature of congenital Horner's syndrome. Vasomotor and pseudomotor changes of facial skin on affected side is seen with patients of central and preganglionic Horner's syndrome and not with postganglionic type, because postganglionic pseudomotor fiber for face, synapsing at superior cervical ganglion, follow the external carotid artery to face, whereas sympathetic fibers to the eye travel via internal carotid artery, carrying only a few sweat fibers for forehead skin. Reduced ipsilateral sweating, but because the pseudomotor fibers supplying the skin of the face run along the external carotid artery, this occurs only if the lesion is below the superior cervical ganglion. Patients may mistakenly interpret the normal side to be sweating excessively. Anhidrosis will not be present in postganglionic neuron as the pseudomotor fibers goes before the postganglionic neuron starts. Next we'll discuss pharmacological tests. In cocaine test, Horner's pupil fail to dilate. Cocaine blocks the reuptake of noradrenaline secreted at the postganglionic nerve ending, which accumulates and causes dilatation of a normal pupil. In Horner syndrome, there is no noradrenaline being secreted, so cocaine has no effect. Hydroxyamphetamine test can be used to differentiate between postganglionic and preganglionic or central Horner syndrome. Hydroxyamphetamine releases norepinephrine from the stores in adrenergic nerve endings, producing significant mydriasis. Hydroxyamphetamine 1% increases the release of noradrenaline from functioning postganglionic nerve endings. In a lesion of the third-order neuron postganglionic, there is no release of noradrenaline from the dysfunctional nerve. A normal or preganglionic Horner's pupil will dilate, but a postganglionic Horner will not. With preganglionic or central sympathetic lesions, pupils will dilate fully and may be even larger than fellow pupils, presumably because of upregulation of the postsynaptic receptors on dilator muscle. In postganglionic lesions, nerve endings themselves are destroyed due to anterograde degeneration, no stores of norepinephrine to release, so hydroxyamphetamine will have no mydriatic effect. Apriclonidine 0.5% or 1% is used. Apriclonidine should not be used in infants, as it can cross the blood-brain barrier. A Horner pupil will dilate but a normal pupil will not be affected because alpha-1 receptors are upregulated in the denervated dilator pupillae. The TOSIS commonly also improves. Adrenaline 0.1% has an action similar to that of phenylephrine, that is, it will cause dilatation only in postganglionic by hypersensitivity. In postganglionic Horner syndrome, the dilator pupillae muscle develops denervation hypersensitivity to adrenergic neurotransmitters due to its dysfunctional local motor nerve. Apriclonidine or cocaine is used to confirm the diagnosis. Hydroxyamphetamine and adrenaline may be used to differentiate a preganglionic, abnormal first or second order neuron, from a postganglionic lesion, abnormal third order neuron. To summarize, cocaine 4% blocks the reuptake of noradrenaline secreted at the postganglionic nerve ending, which accumulates and causes dilatation of a normal pupil. In Horner syndrome, there is no noradrenaline being secreted, so cocaine has no effect. Apriclonidine 0.5% or 1.0%. Alpha-1 receptors are upregulated in the denervated dilator pupillae. Phenylephrine 1% and adrenaline 0.1%. In postganglionic Horner syndrome, the dilator pupillae muscle develops denervation hypersensitivity to adrenergic neurotransmitters due to its dysfunctional local motor nerve. Hydroxyamphetamine 1% increases the release of noradrenaline from functioning postganglionic nerve endings. In a lesion of the third-order neuron postganglionic, there is no release of noradrenaline from the dysfunctional nerve. A normal or preganglionic Horner's pupil will dilate, but a postganglionic Horner will not.